So this lecture will cover Chapter 16, Vector-Borne Diseases. Now again, we're just going to kind of briefly cover the disease processes as far as the organisms that cause these diseases. I will mention them, however, we're not going to go really in depth in those because we will touch on those again in micro. So again, you have terminology that you should be familiar with. So just be sure to review these terms to make sure you understand their meaning. So as I'm sure you're already familiar with, there are several different vectors that can carry different diseases and organisms that cause these diseases. And we see these a lot in different countries. So you can see certain disease processes from various vectors that may be in different parts of the country or different parts of the world. So you may have some things that aren't as common in the United States or not as common in certain areas of the United States. But we all are pretty much familiar that mosquitoes, ticks, lice, fleas, mites, that they all can carry various disease-causing organisms. You know, and here you have an example of some of the more common ones that you are familiar with that are caused by some of these. But also one thing that I want to mention is that as we kind of learn a little bit more about some of these different diseases that are being presented, there's always new things emerging as far as understanding the whole infectious process that happens with some of these vectors. And you may have seen in some of the more recent news that malaria is kind of starting to be more prevalent in the United States, and that there was some original research that was done in the United States that kind of contributed to the fact that we now have mosquitoes that are able to transmit malaria. So the first vector-borne disease that we're going to discuss is Lyme disease, otherwise known as Borrelia. And it is caused by a tick-borne spirochete called Borrelia burgdorferi, and it is a spirochete, and it is one of the major health hazards for human beings and domestic animals. It is transmitted by a hard-bodied tick, and this tick is referred to as Ixodes rechinis complex, and it is found within the host of the white-footed mouse within the United States, in the early stages of the larval and the nymphal stages of the actual development of it. Now, the white-tailed deer is not actually involved in the life cycle of the particular spirochete, but they are the host for the actual adult tick that will actually harbor that organism. Now, these particular ticks are found in more than 30 different types of wild animals and 49 species of birds. So it's not just strictly tied to the white-tailed deer, but that's kind of how we first kind of figured out where these ticks do come from. So illness is not really known to develop in wild animals, but clinical Lyme disease it is seen within domestic animals, including dogs, horses, and cattle. So there are vaccines that are available. I do know for dogs, other livestock I'm not familiar with. Now, of course, you do have to be bitten by the tick in order to actually be infected by this organism, but there are some factors that do influence the chances of actually acquiring the disease after you have had that tick bite. So it's basically going to be based on the likelihood that that particular tick is actually carrying that particular spirochete, and also the likelihood of actually getting infection after the bite from that actual infected tick. Now, Lyme disease is considered an emerging infectious disease due to the fact that there's always a change in environment, socioeconomic factors that can kind of help influence the spread of the particular tick that are infected with this, or the host to this particular organism. Now, basic features are similar worldwide, and at least 60 to 80% of U.S. patients. It will actually begin as that classic skin lesion, that bullseye rash that we are familiar with at the actual site of the bite. So currently, Lyme disease is a global illness, and the cases have been reported on all continents except Antarctica. And since its original description more than 25 years ago, it has become the most commonly reported vector-borne illness within the United States. So about 95% of the cases of vector-borne illness. Now, this is just the cases of Lyme that are actually reported because they've been detected. So many patients go undiagnosed with Lyme, and we're going to kind of talk about a little bit of why that is the way it is. It is a major health concern that is starting to develop, and we're kind of starting to learn a little bit more about the disease process with it and what happens when it goes untreated. And so it has been known over the years to kind of more be concentrated heavily in the Northeast and upper Midwest. However, we are starting to see where it's a little bit more spread out. We have seen it in other countries as well. But just for the fact that the test methods and the education, recognizing those signs and symptoms, and patients are starting to advocate for themselves. So it is being detected a little bit more, and that's why we're kind of seeing it in other states, not to mention travel has kind of helped with patients getting that, and in one state and taking it back to their state, and those physicians may not be as familiar with it. Here in these images, we do see examples or pictures of those ticks, and you can see that they're very small. So in this bottom image here, you kind of see how you've got the fingerprint here, so you kind of know how small this tick really is in comparison to an actual finger pad with that fingerprint on there. So here in this image, you don't see it often, but occasionally you might actually be able to see those spirochetes when you're looking at a CBC sample if it has reached the actual blood. And then of course here, that classic bullseye rash. Not every patient will present with this, and some patients will just have a small rash and not necessarily that bullseye, or they may just have one ring and not that center ring. So every patient can kind of present different, so it's very important to be familiar with the various signs and symptoms. So now let's discuss some of those signs and symptoms. So in some patients with Lyme disease, you actually have a transitory disease process, and so there's little consequence to the patient. And so what this means is just those symptoms are kind of short-lived. You get that initial response, and then basically there's nothing else that progresses from it. But in others, it can become chronic and severely debilitating. So this can happen pretty quickly after the infection, or it can take years for this whole process to kind of set into motion, because there are so many stages of this disease process, and patients do respond differently. So this is why it's very important to be sure to actually get an accurate diagnosis for these patients, because there's so many test methods out there that aren't detecting this disease process, and so there is a need for other laboratory techniques to kind of help with diagnosing this because of the various stages and the ability to detect this disease in those various stages, or to be able to detect the infection at those various stages. Now, how this disease actually enters into the patient. So the spirochete is actually transmitted from the gut of the tick. So once that tick bites the host or the individual, the site of the bite will actually, what will happen is that tick will release those spirochetes from its saliva and its gut back into the host. So when it's feeding off the host, it's also transmitting back. Now, at that bite site, what will actually happen is you will have those spirochetes start to work their way outward through that skin. And so what this migration will actually do is cause this very unique expanding skin lesion that just kind of starts to grow and grow. And we refer to this rash as the erythema chronicum migrans, or the ECMs. And so this is kind of that bullseye rash that we talk about. It's kind of a classic symptom, I guess, so to speak. Now, once that spirochete's kind of done the damage to that localized tissue in that skin, then it will actually start to disseminate to secondary sites and start to cause involvement with other major organs. Now, as far as a little bit of the history, within the United States, there was a case in 1969 in which the rash was actually recognized when a physician had actually gotten bitten by a tick while hunting in Wisconsin. And so that was really the first reported case of the rash, not necessarily knowing what the cause was, but that particular rash. Now, it wasn't until about 1975 when physicians at a U.S. Navy base in Connecticut just started to see a few patients that actually had this rash. And then at the same time, there was an epidemiologist in the Connecticut State Department of Health, and as well as a rheumatologist at Yale University that were notified of these unusual cases that were being presented with arthritis in children that were living in Lyme, Connecticut. And so basically this is when we really started to kind of see Lyme disease more prevalent within the United States, or just starting to see more cases. And so this is actually where Lyme got its name from. It was actually named off of the particular cases that were starting to be investigated within Lyme, Connecticut. Now, as I mentioned, the disease process does happen in stages. So you do have stage 1 where, you know, pretty soon after that bite, you start to see the patient kind of presenting with that rash, as well as flu-like type symptoms, maybe some neurological symptoms. Then from there, it follows a variable latent period, and this is when it kind of just starts to just kind of disseminate out, affecting other organs, invading the nervous system, the heart, the eyes, the skin, just wherever it decides it wants to go and cause a problem. And then you can also have the third stage, where you that can develop weeks to even years later after there's infection. And some of the things that you can see here are arthritis, late neurological complications, so you kind of see those neurological symptoms manifest even more, as well as some other conditions that are kind of more common in those late phases of that disease process. Now, as far as the disease process itself, and the manifestations that happen when you get that disseminated type of infection, you're going to have things like musculoskeletal involvement, neurological, cardiovascular, and so a lot of patients end up getting misdiagnosed just simply because of these symptoms that they are presenting with. When physicians start investigating, they start ruling out everything else, and then the patients ultimately end up with a crazy diagnosis like chronic fatigue syndrome or fibromyalgia, which kind of present in the same way, you know, as far as that pain and fatigue and sleep disturbances and joint pain and stiffness. So again, patients will kind of start off in stage 1 with those flu-like symptoms, possibly upper quadrant tenderness, mild hepatitis, and so they kind of go through that little stage of just not feeling well, so they may not really even be aware yet that anything is being caused by the actual tick bite. And then that's going to be followed weeks to months later, possibly by acute cardiac or neurological symptoms. If the individual, you know, is continuing to be untreated, then it'll kind of progress to the second stage, and then possibly arthritis and chronic neurological symptoms as it progresses to stage 3 in those untreated patients. And so the duration, as far as how long this takes, is going to be different based on the individual and how their body deals with this whole process and what it does to actually try to stop that organism. Now, that cellular immune response to the Borrelia antigens, it begins with that very early clinical illness, and then there's an increase in spontaneous suppressor cell activity, and then a reduction in the natural killer cell activity have also been noted. And then you have mononuclear cell antigen-specific responses that develop during that, as that spirochete actually starts to disseminate out. as well as an antibody immune response that will actually start to follow. Now, when you get that antibody immune response, that's kind of what we're basing that diagnosis on, but those serodiagnostic tests are insensitive during those first few weeks of that infection. So they're not detecting that immune response in that early part of the infection. It actually has to kind of progress a little bit before it reaches a point of actually being able to detect it. So for example, in the United States, approximately 20 to 30% of patients that actually have Lyme disease will have a positive response within those first few weeks. And that's just going to be based off of some IgM isotopes. But by the time that patients actually reach that convalescent stage, which is going to be about 2 to 4 weeks later to have that first initial inflammatory response, about 70 to 80% will actually have some sort of reactivity with that with any sort of serological testing. Now, after about a month of a very active infection, then you're going to start to see those IgG antibody responses taking place. If the disease process is caught by then, antibiotic treatment can start, and then you can kind of start to see those things start to decline, but they may still sometimes be present even after treatment. Now, really doing any sort of immunoglobulin testing for those particular antibodies really shouldn't be done until about 2 to 4 weeks after the patient has started presenting with those symptoms. It's going to take about that long for the body to respond and actually start making those antibodies. Now, in cases of Lyme arthritis, testing for that serum ANA and the rheumatoid factor and the VDRL, those venereal disease research laboratory test, those results are going to be negative. So that's where the diagnosis starts to get thrown off. When you have patients presenting with all this joint pain and you're running the test and there's nothing there, they're getting frustrated, the physician's getting frustrated, patients get labeled as seeking pain meds, but ultimately what's happened is just that the Lyme disease is not at a point that it's being detected, or the physician's not familiar with what's going on in this whole process to be able to go ahead and say, hey, maybe we need to look at this path. So now let's talk about some of those symptoms that often get misdiagnosed. Now, for example, arthritis in patients that have chronic Lyme disease may be associated with a long-standing infiltration of the joints with that actual spirochete, as well as you have some inflammation of the tissue surrounding that whole area. So it's basically got to do with the organism living within that joint. The cutaneous manifestations can be demonstrated as that early rash, that bullseye type rash, but then later on, secondary lesions can start to develop when you have disseminated lesions in the lymphocytoma. So this is going to be something like a nodule that is kind of infiltrated with a bunch of lymphocytes, and they will kind of present as like a bluish red nodule on that layer of the surface layer, kind of subsurface, but within the skin, so you can actually see it, you can visualize it, and sometimes you can actually see it in children on their earlobe or on the breast in adults. But again, that is something that kind of, as it progresses, you'll kind of see that developed. And then you also have late lesions. These are referred to as ACAs, and they too kind of have that darkening coloring with a little bit of fibrosis involved as well. You can also have cardiac manifestations that will happen, and so if patients are left untreated, then they can actually have an onset of symptoms even after later in the disease process. They can start having these cardiac symptoms that will kind of fluctuate a little bit. Now, with patients that start to develop, cardiac types of symptoms, then you'll start seeing signs of like lightheadedness, syncope, passing out, palpitations, chest pain. So you can really tell that it's really doing something with that heart. So again, because of these symptoms, presenting with the heart, if the patient was never diagnosed from that initial rash and it's disseminated to the point of affecting the heart, then obviously most physicians are going to go down a different path of trying to diagnose some sort of cardiac condition, when ultimately it's just the damage that is done from that dissemination of that Lyme disease. Patients can also have neurological manifestations, which can include things like aseptic meningitis, cranial nerve palsies, a peripheral neuritis, peripheral neuropathy. So you can actually have a lot of symptoms that will manifest within that neurological system. And so you can also see things months to years after that initial infection, where patients can start to have things like chronic encephalopathy, polyneuropathy, so they've got just widespread pain throughout their body, that neurological nerve pain. You can also have leukoencephalitis, as well as various manifestations that can affect the eyes. Now, there has been reported cases in which an infected mother has transmitted or has had a transplacental transmission of the Borrelia to the infant. And so, there has been and these are basically in cases, or have been cited in cases in which the infant died shortly after birth, and the mother had actually acquired the infection during the first trimester and had actually received very little treatment or no treatment at all. And so these are the cases. So that's not to say that, if a mother transmits to the baby that the baby is going to die. It just means that these were some cases in which it was actually observed. I'm pretty sure that there's plenty of individuals that have had a Borrelia infection and went undiagnosed and still had children, and the children, did survive and did fine. However, there are cases in which it has been seen that it has been transferred from mother to infant. So, with research, I'm guessing that someday we will find that there are patients who never were bitten by a tick but have Lyme disease simply because it was transmitted from mother to infant. And there's also, if you do a lot of research, there's also incidences of cases in which it has been sexually transmitted. Now, actually culturing this particular organism is a little bit difficult, although it can be seen in blood cultures, spinal fluid, but as far as just a random culture growing the Borrelia, it's not going to be very common. So most of what you're going to see is going to be some of the serological testing that's going to help to identify. Now, again, your first step is basically going to be to do an enzyme immunoassay or indirect immunofluorescent assay. And if they're negative, then you don't go any further. Now, if those tests are positive, then the CDC does recommend that you do the screening type of testing first, the EIA or the indirect immunofluorescence, and then if that's positive, then you would do a confirmation, so to speak, or if you have any sort of indeterminate or equivocal type of reaction, then you would proceed to a second step. Now, the second step is going to use the immunoblot procedures, which we refer to as a Western blot test. Now, something that I do want to mention, the CDC does have criteria out there of what is considered a positive test when using a Western blot to actually diagnose the patient. Now, when you do the Western blot, you are basically looking for reactivity to some major surface or flagella proteins that are actually within that Borrelia organism. And so when you're doing this test, you're looking for that reactivity at specific bands. So here we have an example of some of those different bands. And one thing to note, there are a couple of bands that were placed into vaccines in the 90s. So there was a Lyme vaccine that was made in the 90s, and it did go through, it did go out through clinical trials and actually given to some people. So that vaccine was actually created based off of some of those surface antigens and proteins of that particular organism. So two of those particular bands that show up on these strips for the immunoblot represent those particular proteins that are in that vaccine. Now, because the vaccine was distributed in the 90s, the CD said that we cannot use those particular bands to actually aid in the number of bands that we have to get positive in order to confirm that a patient does have the Borrelia present. Now, with that particular vaccine and ruling out those two bands, I do want to make mention that that vaccine was pulled from the market due to some adverse side effects. The CDC has not reversed that ruling that we can no longer use those two bands. So that does make it a little bit more difficult, even though the vaccine is not on the market. And that is the most common two bands that are present within that organism that patients will present with. So that's why those two were picked to be used. However, a patient could not have received the vaccine, still have two of those bands positive, or those particular two bands positive, as well as some of the other bands. So you can see some of the different bands that are tested for, and you have to have a specific number in order for the test to be called positive. However, if those two bands are included in the number that are positive and you're not allowed to count those, then a patient ultimately could be misdiagnosed. So that is a little fun fact, that there was a vaccine in the 90s that was pulled from the market, but I digress. Now, so there are additional testing that are kind of coming out, PCR testing, looking for the organism in the spinal fluid as well as the joints. Other samples are kind of being experimented with as well. And so what that's actually doing is looking for the DNA of that organism to be present in that patient. And so that PCR testing is actually going to amplify that DNA activity to hopefully be able to provide a better diagnosis for that patient. Now, sometimes you will have testing looking for the Borrelia will be done on spinal fluid. So if the disease does disseminate to the point of causing those neurological conditions and migrating to the spinal column, then physicians may opt to actually do a spinal tap. It's not as common. Most physicians don't want to jump right in and do a spinal tap to try to diagnose Lyme disease. They're going to go through a process of ruling everything else out first, depending on the physician. Some of them don't even believe in testing the spinal fluid. And this is because only about 20% of patients will actually present with an organism in the spinal fluid. So they're a little bit more hesitant to do that particular type of testing. However, if you do have a patient that presents with those neurological symptoms, then the physician may opt to go that route. Human ehrlichiosis. So tick-borne rickettsia of the genus Ehrlichia have been recognized as the cause of human illness within the United States. And this is due to the Ehrlichia species that belong to the same family as the organism that causes Rocky Mountain spotted fever. And we'll talk a little bit more about the particular organisms as we get into micro. But for now, just kind of understand that ehrlichiosis is a general term for anaplasmosis in human monocytic ehrlichiosis. Now, the prevalence for this disease is low within the United States. Some fatalities have been reported. Incident rates increase with age and are higher in men than women, simply because more men usually do go out hunting. Human ehrlichiosis does most frequently occur within the southern mid-Atlantic and south central states. Of course, our vector is the Lone Star tick, with the white-tailed deer as the principal reservoir. So basically, they're the ones that's going to kind of carry it around. Now again, this is another one of those illnesses that's very hard to recognize early on, simply because of the symptoms and how it presents, with an acute febrile type of reaction, flu-like symptoms. So most patients aren't really suspected of having any sort of disease process caused by this until later on, when they're just continue to not feel well. And they're going back to the doctor, and finally the physician will start looking at some of these tick-borne illnesses. So early detection is very key, because this particular disease process can actually be fatal if it's left untreated. So trying to actually diagnose human ehrlichiosis. So laboratory studies have actually indicated that there's some sort of hematological, hepatic, or central nervous system involvement within this disease process. So the definitive diagnosis is based on the actual inclusions that we see within our white blood cells. And so what you're actually looking for is the presence of those Ehrlichia within the cells itself as it goes through its various stages of development. So first you have those elementary bodies that will actually enter into a leukocyte by phagocytosis, and then from there they'll start to multiply very rapidly. After about 3 to 5 days, a small number of tightly packed elementary bodies will actually start to be visible, and then during the next 7 to 12 days, the initial bodies will start to develop into a more distinct form, or what we refer to as a mulberry form. So they're basically going inside of that cell and using that cell as a place to replicate, and then once they've reached that point, they're expelled out, and then they can kind of go in and start invading other cells. Now, some of the testing that we can do in that very early acute stage of illness, when you're actually going to start those antibiotics, would be to do some PCR testing on a skin biopsy of the rash, or the EDTA whole blood sample. Specific immunohistological detection of rickettsia in the skin biopsy, or of the rash or the eschar that forms from that actual disease process. And with that, they're just basically looking for a specific titer to be reached when they're doing that testing. Now, patients are treated with doxycycline in order to clear out this particular organism. Rocky-mounted spotted fever is a tick-borne disease that's caused by Rickettsia rickettsii. And this particular disease process can potentially be fatal to humans. It is transmitted by the bite of the tick that will, and actually this is called the American dog tick, or the Rocky Mount wood tick, and the brown dog tick. Now, there has been a new category that's kind of been found that's called spotted fever rickettsia. Now, the new category captures cases of Rocky Mountain spotted fever, as well as some others within it. So it's still kind of being researched a little bit more, kind of understanding a little bit more, but it's basically kind of divided out with the different areas and transmission as far as how this illness takes place. Now, signs and symptoms. The first symptoms of Rocky Mountain spotted fever typically begin within 2 to 14 days after the bite of an infected tick. It begins as a sudden onset of fever, headache, and some type of rash during the course of illness. Symptoms may also include nausea and vomiting. So again, you're getting those flu-like symptoms. Okay, so as far as diagnosis, blood specimens are not always useful in order to detect the actual organism through PCR assays or culture. So if the patient actually has a rash, PCR testing and immunohistochemical staining can be performed on an actual skin biopsy that's taken from the rash site, or on an actual autopsy sample. So what this can do is actually yield rapid results with good sensitivity. When you're actually looking directly at that tissue specimen, that was collected during that acute phase illness before an actual antibiotic treatment has been started. But a negative result should not be used in order to judge, treatment decisions as far as that goes. Just because you don't see it in those methods does not mean that the patient doesn't have it. So we're kind of going back to that Lyme disease theory. So what actually happens during the infection is that a patient's immune system is going to start to develop those antibodies to the rickettsia, and then from there those antibodies usually aren't detectable in the first few weeks of illness in about 85% of the patients, so they'll get a negative result. Even though they are infected, it's just not being detected yet. So the gold standard of the serological test is going to be doing that IgG immunofixation assay titers in order to diagnose it. And you'll do this by doing 2 paired serum samples that are actually going to start to demonstrate that there's some sort of rise in those antibody titers. So you're going to do a first collection, and then you're going to do sometime later a second collection, and you're going to look for that rise in those actual antibodies to take place. So typically you're going to take that first sample very early in the disease, like as soon as you suspect this may be it, and then usually within the first week or so of those symptoms, and then the second sample is going to be taken about 2 to 4 weeks later, so that you can actually give the body time to have that response, and then that's going to show you whether or not you have that significant 4-fold rise in those antibody levels. Now your IgM antibodies usually do rise at the same time as those IgG, which is going to be near the end of the first week, and then they're going to remain elevated for months. And in some patients, you can actually see these levels be elevated for years after the infection has been treated. So also, IgM antibodies are less specific than IgG antibodies, and they are more likely to cause a false positive result. Therefore, physicians that are actually requesting you to do an IgM titer should also be running that IgG titer as well, just to kind of rule out any of those false reactivity. Treatment for Rocky Mount spotted fever is going to include doxycycline. Standard duration is about 7 to 14 days as far as for that treatment. Babesia, rare, severe, sometimes fatal tick-borne disease that's caused by different types of Babesia. And basically you can see that organism microscopically after it starts to infect those red blood cells. Now it too is transmitted by a tick, and those early stages of tick development are actually carried on that white-footed mouse again, and then the later stages will be on that white-tailed deer. So I feel sorry for that poor white-tailed deer. It's taking all the slack for all these diseases. Now Babesia is most common in older individuals, as well as patients that no longer have a spleen. And as you know, the spleen is going to kind of help remove anything that's kind of abnormal with those red blood cells. It's kind of the inspection factory there. So if a patient doesn't have a spleen, then you're going to see that Babesia in there because the spleen's not helping to remove it. And you can also see it being more common in your immunocompromised patients. Now, there have been cases reported of transfusion-related diseases or Babesia. Because obviously if the organism is in the blood and it gets transfused, you're giving it to the recipient. Signs and symptoms. So the incubation period is approximately 7 to 21 days, and the presentation of these symptoms can be variable, anywhere from asymptomatic to rapidly progressive and sometimes even fatal. The disease can cause fever, fatigue, hemolytic anemia that's going to last several days to several months. And it can actually take 1 to 8 weeks for the symptoms to appear. So again, this is another one of those processes where you're kind of mimicking other stuff, so the diagnosis is going to be a little bit harder. So the fact that patients have to be aware that they have recently been bitten by a tick, it's going to help aid in diagnosis and actually start some of this test process a little bit earlier, before it actually gets too severe for the patient. So of course diagnosis is going to be based off of seeing that organism when you look in the microscope, and this has kind of been the gold standard for over the years. Pretty simple to do. It doesn't take a lot of resources as far as to do this, and of course you would examine a thick and a thin blood smear, looking for those organisms to actually be present. So you're looking for the appearance of that classic Maltese cross, but you can also see some of the other forms. You can see those ring forms, that cross form. So anyway, you're looking for that when you're actually trying to diagnose Bavasia. Now there are other test methods out there. Looking for those antibody titers can be helpful. When you're actually checking those titers, you can actually see if they're going up, coming down, kind of know where they're at in that disease process and whether or not treatment is actually working. Doing molecular type testing can be helpful, PCR testing. So as some of these newer methodologies are developed, we're going to kind of start seeing that a lot of this stuff is going to start being a little bit easier to diagnose. As far as any kind of like rapid test for Bavasia, there's nothing really out there. Nothing to really screen potential blood donors or anything like that. So, you know, we still have a lot of work to do as far as diagnosis of a lot of these vector-borne diseases. Now, standardized treatments as far as for Bavasia going to include things like antimicrobial therapy for the patients that no longer have a spleen or who are immunodeficient. Some drugs that have been used to treat malaria have also been seen to be very effective against this particular organism. Oral erythromycin, oral antibiotics may be used for treatment, as well as just trying to prevent it. So there are some different regimens that they kind of use in combination. Quinine is one of those. So just, it's kind of a combo treatment using multiple things to kind of treat the disease process and to eventually kind of eradicate it out is pretty much the treatment process for Bavasia. Now there has been some success with exchange transfusion. So when you have patients that are so heavily infected with this particular parasite and they have you know, they're in a severe disease state, they're actually having a lot of hemolysis from it, doing that exchange transfusion, so basically replacing their blood as much as you can with donors can sometimes kind of help to treat those symptoms for those patients as well. Chikungunya disease, now that's a mouthful to say, but this particular disease is a virus that's actually transmitted to humans through mosquito bites. Now, it's not common in the United States, but there have been a couple of cases that have been noted in recent years. So therefore, I just will kind of present it to you. Most of it's going to kind of have outbreaks in like Africa, Asia, Europe, and other parts of the world. But signs and symptoms begin within 3 to 7 days after being bitten by an infected mosquito. Patient can develop fever, joint pains, that's going to be the most common, but also headache, muscle pain, joint pain, swelling, rash. So again, those flu-like symptoms. If it is suspected, now again, it's not very common, so this is probably not going to be the physician's go-to when he's trying to rule in and out you know, what diseases are happening or taking place in this particular patient. However, if for some reason they do go down this path, what you're going to actually be looking for is those IgM and IgG antibody using that enzyme-linked immunoassay type of testing. Dengue fever. So there have been a few more cases of this within the United States than the previous one. And so we are kind of starting to see it a little bit more in like California and Florida. There's also been some incidences reported in New Jersey and New York. Guam, some of your more tropical areas have seen transmission as well as travel-associated transmission that takes place. Now it can present a couple of forms, the dengue hemorrhagic fever as well as dengue shock syndrome, and they are caused of the various viruses that are transmitted by mosquitoes, and those particular viruses can actually be divided up into 4 different serotypes. And again, we'll kind of get into this a little bit more once we're in micro. So just for now, kind of understand that, it is endemic to other areas of the world, although there are some more cases that are kind of being present within the United States. Now, as far as signs and symptoms, patients can present with abdominal pain, tenderness, persistent vomiting, fluid accumulation, mucosal bleeding, lethargic, restlessness, liver enlargement, severe bleeding, organ involvement. So as you can see, it can kind of mimic other things. So it can kind of, again, throw out that investigation process a little bit. Now, this is not a list of all the different symptoms that can happen, but it just kind of does give you an idea of how this disease will actually start to kind of present. Now, as far as test is involved, detecting the viral nucleic acid or antigens as well as antibodies is pretty much how it is diagnosed. But something that's kind of interesting is that you can actually do a tourniquet test for these patients to kind of help you determine which route to go as far as which disease process to look at. Now, what a tourniquet test actually does when the patients are kind of presenting with these GI type symptoms, you're not really sure if it's something else going on. So if you wanted to kind of do, a quick rule in, rule out, just to kind of differentiate between a patient may have some sort of acute gastroenteritis from dengue fever, then you would do the tourniquet test. And so with that process, you could use like a blood pressure cuff, and then there's a certain time frame where you leave it on and then you let it down. And then once you actually look at the patient's skin, you're looking for the presence of petechiae to be present to indicate that you actually have a positive tourniquet test. So that's really a very early indicator to kind of help the clinician try to rule out the possibility of the dengue fever if they have the patient present like this. They could do that really quick, see if it's present. If that's positive, then they know they need to probably be looking at some type of dengue fever or something where there's some kind of hemorrhagic type of aspect to that disease process. West Nile virus. So most of you probably have heard of this. It is a member of the Japanese encephalitis viruses. It does cause febrile illness, encephalitis in human beings, and it is a mosquito-borne pathogen. Now, we have seen cases within the United States, and therefore this is one of the diseases that is tested for within blood products now, because it is kind of being seen a whole lot more within the United States. And signs and symptoms are fever, headache, fatigue, aches, rash. They can last days to weeks. So again, those flu-like symptoms, it's pretty common with all of these. Now, as far as diagnosis, you're looking for viral isolation and serological testing in order to kind of diagnose and confirm this particular disease process. So basically it's kind of hard to really go in thinking that you've got this, because a lot of us get bitten by mosquitoes, and you're really not sure if you're going to catch anything with it. But if you've been outside recently and you start kind of presenting with these flu-like symptoms, this probably should be in the back of your mind somewhere that this could be a possibility. There's really no specific treatment for West Nile virus. Patients that have milder diseases kind of will resolve over time. Patients with more severe diseases can occasionally need to be hospitalized just for supportive treatment, kind of treating the symptoms at this point. But otherwise, it's pretty much going to be self-limiting. It's just you don't want to take a patient that's already in the hospital, who's already sick and immunocompromised, give them a transfusion, and then add to it with a viral infection. It's just not good practice at all. Zika virus. So this is actually spread by the bite of an infected mosquito. Outbreaks have occurred in many different locations throughout the world. If a patient is infected with a mosquito, with a Zika virus or bitten by a mosquito, that mosquito can actually take that viral infection, and then that mosquito is now infected, and then that mosquito transmits it to somebody else. So that's kind of how it starts to spread, is just popping around from one person to another, just sharing virus diseases. So obviously you kind of can think, you know, some of these mosquitoes can carry multiple diseases within them. So, you know, mosquito bites are not something to play around with. Now, the crazy part about Zika virus is not only can you be infected by a mosquito, but there's also 3 other modes of transmission. So a pregnant woman who already has Zika virus can transmit it to her fetus during pregnancy or anytime around the time of birth. So there's not actually been any reports of getting Zika through breastfeeding. So that currently is not really something that we're looking at. But in addition, Zika can actually be transmitted through sexual contact. Even if the infected person does not have any kind of symptoms at the time, they can actually give it to a sexual partner. And the other route of transmission would be through transfusion. Now, currently there aren't any confirmed cases within the United States of a patient contracting Zika virus through a transfusion. But there have been reports in other countries like Brazil in which it has happened through a transfusion. Now, as far as within adults, the symptoms are mild, can include fever, rash, joint pain, conjunctivitis. Less common will be muscle pains, headaches. So again, you're kind of getting those same symptoms. The problem comes in when there's an infection during pregnancy, because it can actually cause birth defects and microcephaly, and so this is actually caused by an incomplete brain development and other very severe fatal brain defects. And so you can see that example here in this image where that infant's the head of the infant actually doesn't develop to the typical size that it needs to. So it's actually a little bit smaller because of that malformation within that brain. And so, you know, that's going to be the major complication of this viral infection, is if it is actually infected someone during pregnancy, and so then it causes this malformation. Now, as far as diagnosis, molecular assays are used looking for that viral RNA early on in an infection, as well as serological testing, where you're looking for those antibodies that develop towards the end of the first week of actually having that illness. Now, unfortunately, there is no vaccine or any way to kind of prevent this infection, so it's actually very sad that you know, pregnant mothers can actually contract this virus and then ultimately have this complication that comes with it, with really no options.